Hello, and welcome to another lecture from my class on the psychological aspects of drug use and abuse. In this lecture, I'm going to be continuing to talk about treatments for drug and alcohol problems. I'm also going to be reviewing a few points from last time. Now, one bit of review is this. You remember, I hope, that I showed this image, and it's trying to describe the different pathways that people can travel down when they move from recognizing that they have a drug or alcohol problem to some sort of an outcome, hopefully an outcome that involves recovery. That is, to either stop using drugs or use them in a safer, more controlled way. Now, these different pathways can include things like quitting or cutting down use on your own, sometimes called spontaneous recovery, recovery using self-help groups. I'm going to talk a little bit more about that today, or recovery using different options for professional treatment. In the last class, I focused a lot on motivational interviewing as a form of psychotherapy that's associated with the stages of change model. And one of the things that is really nice about motivational interviewing psychotherapeutically is it works really well with people's ambivalence towards their drug use. I recall that I said early on in treatment, especially if a person is at the contemplation stage of treatment, he or she may feel mixed emotions towards their drug use. They may have reasons that they want to move towards recovery or towards change, or they may have reasons where they want to move away from recovery or away from change. And what you can do with motivational interviewing, using some of the techniques that I described, is you can work with people so that they can acknowledge their ambivalence and hopefully recognize that the majority of their feelings lie in the direction of changing, lie in the direction of moving towards recovery. It's not in and of itself a complete therapeutic technique. You wouldn't use it as the only form of treatment for a drug or alcohol problem, but it can be a really valuable tool. It's one that I was trained in when I was in graduate school, and I've used somewhat since that time. It can be really, really cool. And so again, I talked about it last time. I want to briefly review it today. Moving on then, I want to talk just a little bit more about community support groups. I mentioned those last time. Then I want to introduce the biopsychosocial model, which is a way that we think about various types of options for treatment, including professional treatment, formal treatments for drug and alcohol problems. I'll talk a little bit about detoxification as well. That's one of the formal treatments we sometimes use for drug and alcohol problems. And I'll talk a little bit about pharmacotherapy, or medications that we use for some types of drug or alcohol problems. I won't talk a lot more about psychotherapy in this lecture, but I will in future lectures. So if you're waiting for that, you'll have to wait just a little bit longer. But hopefully what I'll present today will be interesting to you. Okay, so here's our diagram again. It hasn't changed, but just to orient us, we're kind of at that point there where the person has, let's imagine, recognized that he or she has a problem with drugs or alcohol. Maybe they've been unsuccessful in quitting or cutting down on their own. Perhaps they're interested in different self-help groups that exist in the community and or seeking professional treatment. Now, last time when I talked about community support programs, I focused mostly on Alcoholics Anonymous and the related group Narcotics Anonymous and other 12-step programs, which are programs which are more or less based on the Alcoholics Anonymous or the AA model. There are other options for community support groups, ones which aren't based directly on 12-step. One of these is called SMART. SMART stands for Self-Management and Recovery Training, and it is a form of community support group that's more closely associated with cognitive behavioral therapy, a form of therapy I'll describe in the future, than it is associated with the 12-step program. So it has a somewhat different approach to helping people and supporting people in their movement towards recovery. Particularly what SMART and similar programs like it do is they help people identify and change irrational or illogical or just plain unhelpful beliefs that they have about drugs and alcohol that may be perpetuating their drug use. So it's kind of like what a client might do individually with a cognitive behavioral therapist in individual treatment, individual psychotherapy, but he or she practices these techniques with a group of folks out in the community, hence a community support program. Let's look at how this might work. You could imagine that there is, for a particular person, a drug user, let's say an alcohol user, an activating event in his life or in her life. The person goes to a party. And that can be associated with certain sorts of beliefs, or that could trigger certain sorts of beliefs or thoughts that they have. Things like I have the belief that I need to seem cool and relaxed when I'm at a party, or drinking alcohol, that is, helps people to seem cool and relaxed. Those are ideas or beliefs that the user holds in his mind or in her mind. They may not be entirely aware of them, but they are there in their mind, and unfortunately they can be connected to feelings and behaviors which may be unhelpful. So for instance, if the person goes to the party, if they hold the belief that they need to be relaxed and confident and cool at a party, they may have a consequential emotion of feeling anxious when arriving. Like, gosh, I really feel like I should be relaxed, but I'm not. That makes me feel even more anxious. They may also have a thought as a consequence that they need to drink alcohol. I know that drinking helps people to seem cool and relaxed. I really need to feel cool and relaxed. I'm having a thought like I need to have a drink of alcohol, which, if you're trying to quit or cut down your use of alcohol, obviously isn't an ideal thought to have. Now, these thoughts and emotions may in some way influence one another, but ultimately they can influence behavior, which is the person can choose to drink alcohol, which, again, for many people who don't have drug or alcohol problems isn't particularly a big deal, but for someone whose goal is to cut down, reduce use of drugs or alcohol, this is not a good outcome. So you can see how the thoughts and the beliefs, particularly the beliefs about needing to feel relaxed, needing to drink alcohol in order to feel relaxed, those beliefs play a role in a negative outcome for this person. Of course, the emotions can influence the behavior as well. These things are all, in one way or the other, interconnected. But the important thing is that those beliefs are problematic, or they play a role. What if we could change them? What if we could get the person to feel or think slightly differently in that situation? Again, the person goes to a party. So I suppose it's possible for the person to just avoid going to parties, but that's pretty unrealistic for most people if they want to have a social life. You'll eventually have to go to some sort of a party. What if, instead of having beliefs like, I need to seem relaxed and cool, drinking helps people to seem relaxed and cool, the person could identify those as irrational, meaning they're not exactly rational, they're not exactly logical, or at the very least they're not particularly helpful in this situation. Once the person has practiced this form of psychotherapy, he or she gets a little bit better at noticing when they have those beliefs lingering in their mind, and then replacing those beliefs with others that are more rational, or at least more helpful. Beliefs like, I don't need to seem relaxed and cool, at least not all the time. That's, no one's that way all the time. And drinking doesn't help me anyway. So even if it is the case that it's nice to seem relaxed and confident and cool at a party, I know for me that drinking really isn't helpful. It doesn't get me all the way to where I need to be. So I've changed those irrational, kind of unhelpful beliefs to beliefs which are somewhat more rational and accurate, and also just plain more helpful. If I can do that, if I can practice that and get confident in my ability to shift those beliefs, then as a consequence, my emotions are different. The person's emotions are different. He or she feels less anxious. He or she has slightly different thoughts which aren't so pressing about needing to drink. So instead of having the thought, I need to have a drink, the person has the thought like, well, I don't really need to have a drink. I sort of want to, maybe, but it's not a need the way it was before, when I used to believe differently about myself. And as a consequence of all this, hopefully the behavior is that the person is less likely to drink. It's not an absolute guarantee, it's not a perfect promise, but if the person, through the support of their community group and through practicing the techniques that go along with SMART, is better able to change his beliefs, change her beliefs, it's likely that over time they're going to be drinking less when they go to a party. And maybe that's the goal. They may not be trying to entirely stop drinking, but just have a bit more control over when and with whom and how much they drink alcohol. That's the basic idea, changing beliefs so as to change thoughts and feelings, and especially behavior that flow from those beliefs. Now you can ask, what's different about this from 12-step programs? Well, there are a couple important differences. One is in SMART programs or rational recovery programs or similar programs like this one, there's usually not any sort of emphasis on a higher power. Remember last time that 12-step programs, especially Alcoholics Anonymous in its original form, do focus on the idea of some sort of a God or divine power which helps to support the user. And for some people, if you believe in God, maybe that's a fine thing. But if you don't believe in God, or if you're uncomfortable joining a new religious or quasi-religious movement, the idea of a recovery program that doesn't really emphasize God may be attractive to you. Another difference is that abstinence in SMART and similar programs like Rational Recovery, and there are other ones out there, abstinence here isn't always the goal. You could have the goal of being abstinent, but you might choose to have some different goal. Like, I want to not become abstinent from drinking, instead I want to just drink in a controlled way. And by controlled way, I mean I want to only ever have a maximum of 2 drinks per drinking session, or I only want to drink when it's on the weekend, or blah, 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 and blah. Those are differences because in 12-step programs, especially Alcoholics Anonymous, the only real goal or the only acceptable goal is to become truly abstinent. That is to say, to not drink alcohol at all. So if your goal is abstinence, either one could be fine, but if your goal is not abstinence, then it would be hard probably for you to fit into a 12-step program. You might instead prefer some sort of a SMART or rational recovery type program. Now you can ask, does this program work, or do similar types of cognitive behavioral flavored community support programs work? Well, the answer is that generally speaking, and there's a fair bit of research on this, that they tend to be fairly effective. And they tend to be comparable to 12-step programs. It isn't really the case that there's one type of community support program that's much, much better than other types. What is the case is that generally speaking, these types of programs are helpful for most people. They're helpful for some people more than for others. Some of it may have to do with finding a match between the type of goals that the particular person has, whether or not she wants to do something that involves God, whether or not she wants to do something that involves total abstinence, and the types of resources and supports that the particular program can offer. What's nice about these types of programs, it's true for AA, it's true for SMART, it's true for Rational Recovery, is that most of them tend to be fairly easily available in the community, and most of them tend to be free. So the important point here is that there are different forms of community support. 12-step, and by that I mean just sort of generically AA and similar types of programs, aren't the only option, even though they are the most common. I think in most communities you're more likely to run into or find a 12-step program or an AA type program than you are to find a non-AA community support program. But depending on where you live or depending on how large your community is, there are probably other options, and generally speaking, most of them seem to be pretty helpful, which of course is good, because if you're someone who has a drug or alcohol problem, it's worth looking around to see if, at your church or at the community center or the gym you go to, or, check Craigslist, check the classifieds in the back of the local newspaper, see if someone in your community is getting together to provide some support and recovery. You're likely to find that someone is, or some group of people are, and you can join them, and that could be really helpful. And as a healthcare professional, I would encourage that if you have, or if you think you have, a drug or alcohol problem. So again, I know I've showed this picture a bunch of times now, but just to orient us, we're just getting the sense that there are different ways for moving from the left side of the screen, where the person's in a state of having a problem, maybe recognizing the problem, towards the right side of the screen, where they're hopefully recovered or recovering or in a state of recovery. Now, so far we've talked about quitting on your own in the last class, community support programs or self-help programs in the last class and in this class. Now let's move on to talk a little bit about professional treatment. What goes into professional or kind of formal treatment for drug or alcohol problems? Well, there are a lot of different things that could be considered professional treatment. And what I use, or to think about these, or kind of organize all the different options, is the biopsychosocial model. Now, if you've taken another psychology class or biology class, you've probably heard this term before, especially if you've taken like an abnormal psychology class. Even if you've never heard this term before, you can almost certainly guess what it means. It means that in the case of drugs and alcohol use, there are biological, psychological, and social variables or factors which contribute towards use. And therefore, in the context of treatment, we might seek biological, psychological, and social treatments to address those different variables or address those different factors. So what are these? Well, when we think about biological factors, we know that for many forms of drug use, the mesolimbic dopamine pathway, the reward system plays a role. This is the system within your brain that, generally speaking, gets you motivated to move towards and engage in all sorts of different behaviors, many of which, of course, are perfectly healthy, like eating food or escaping from danger or having sex or doing things which you need to survive. The problem, at least for some people, happens when this system becomes overly activated in the presence of drugs, where you start to pursue the behavior of drug use more than you pursue the behaviors of food and safety and sex and healthy relationships and so on. And drugs which powerfully activate this system, for instance, drugs like alcohol, or maybe even more so, drugs like the stimulant drugs, can be really very addictive. Cocaine powerfully activates this system. It's no surprise that cocaine is a pretty addictive drug, at least as compared to some other drugs which don't activate this system quite so much, like, for instance, LSD. So one of the biological factors is this underlying reward pathway. So again, drugs like opiates, cocaine, nicotine, alcohol, pretty much any drug that you can get pretty addicted to is likely acting on this pathway at least a little, and often more than a little. So we'd like to be able to provide treatments that address, or interventions that address this biological factor or this biological variable. Dopamine pathways associated with craving and with drug-seeking behavior. I've already said that, it's a bit of a review. One part that I didn't really mention up until this point, but it's relevant here, is that although we call it the mesolimbic dopamine pathway to suggest that mostly the neurotransmitter involved is dopamine, there are other neurotransmitters involved as well, including opioids. And for instance, or particularly within the reward pathway, in an area called the nucleus accumbens, there's a subtype of opioid receptors called the mu opioid receptors. You can see them kind of indicated here. And these are associated not so much with the craving for drugs as the sense of pleasure you receive when you have drugs. So again, this nucleus accumbens activity is associated with pleasure. And to be clear, this could be pleasure for healthy things. If you have sex and you have that sense of pleasure, if you eat a really good meal, you have that sense of pleasure, you're enjoying, like, cuddling with a family member or a good friend. If you cuddle with your friends, I don't know, depends on how close you are, I suppose. That good, warm, like, feeling when you get the thing you want, that's the activity of this subsystem within the overall dopamine pathway. And it involves a set of receptors that respond to a particular type of opioid. Now, in the case of some drugs, those drugs also activate those receptors, which explains, at least in some way, the intense pleasure people feel. So, opiate drugs like heroin, for instance, or fentanyl or OxyContin, those drugs activate opioid receptors of various sorts, including the mu opioid receptors in the nucleus accumbens, which probably explains why when you use heroin, when you use fentanyl, you have a strong rush of pleasure initially when you first use it. Why I'm bringing this up now is because some of the drugs which are useful for treating drug addiction, at least some types of drug addiction, are drugs which are opioid antagonists. So for instance, we've noticed over the years that drugs like naltrexone, for instance, which block various opioid receptors, not only can be used for treating people who are in acute overdose of a drug. So if you've overdosed on heroin, for instance, if you overdosed on fentanyl, you can give these drugs and it will save the person's life because it'll pull them out of their coma. It will stop them from dying because you're blocking the activity of the drug. But they can also be given on an ongoing basis to cut the craving and cut the satisfaction people feel from using drugs. Not all drugs, but it seems to work especially for opiates, but also for alcohol, probably because alcohol also activates this mu opioid receptor in the nucleus accumbens. So if you're taking regularly your naltrexone or other drugs which include naltrexone or similar pharmacological agents, what you typically feel is less pleasure when you use the drug. It doesn't take the pleasure away entirely, but it blunts the pleasure. So if you don't have as much pleasure from using a drug, there's less potential for positive reinforcement, and over time, hopefully, you use the drug less and less. You decrease your use of the drug. That's an example of a biological variable or factor, that is, the particular physiology of this reward pathway being exploited or used to help with treatment. So biological factors in the biopsychosocial model. How about psychological factors? Well, there certainly is a lot of psychology that goes into drug and alcohol use. I've hopefully tried to explain that over the course of the whole semester, but one of the factors, or one of the variables I keep returning to again and again, are cues that are associated with drug use. So for instance, if you use drugs repeatedly over time, various aspects of your body, the environment, the setting, even of the time of day can become associated with those drugs, those via classical conditioning. And those cues then can become triggers that can activate feelings of craving. So for instance, if you smoked cigarettes for any amount of time, as I've told you in previous classes and lectures, I used to smoke, the holding of a cigarette lighter, or the sound, the click that it makes when it lights up or when it sparks up, that for me, even after all these years, is still kind of a trigger. Like if I hold a cigarette lighter, if I click it, like if I'm lighting candles on a birthday cake, there's this really brief moment where I sort of have a craving for nicotine. Why is that? Well, it's because for years when I used to smoke, of course, every time I lit up a cigarette, I was using a cigarette lighter, probably one like this picture. So that's a psychological variable, cues that are associated with drug use via classical conditioning, and they can play a role in people's drug use. Other psychological variables are things like beliefs or expectancies, attitudes, beliefs, thoughts that people have about their drug use. And that is related, those are related and can contribute towards drug use. So to the extent that you think of drug use as normative for your social group or important for how you're supposed to socialize or interact with people, those beliefs of course will encourage you to use alcohol or encourage you to use drugs. To the extent that you hold beliefs that alcohol or drug use is not particularly important to you or is perhaps even dangerous to you, that will tend to decrease your drug or alcohol use. So how does this all work in terms of treatment? Well, a lot of the psychotherapies, including some of the ones I'm going to describe in the future, involve helping people to recognize and, if possible, avoid cues. So kind of acting on that one part of psychological in the biopsychosocial model, and to change their beliefs or attitudes about drugs or alcohol. So acting on that other variable or that other aspect of the psychology in the biopsychosocial model with the hope that you decrease use. So if you're in cognitive behavioral therapy, as I've discussed in previous classes and as I will discuss in future lectures, cognitive behavioral therapy is a type of psychotherapy that involves learning skills, and they're largely things like learning to recognize and avoid cues or triggers for drug use, learning to recognize and modify your own thoughts or beliefs about drug use, with the overall goal of making it less likely that you'll slip into a pattern of behavior that involves drug use. So you can see kind of working with or intervening with, exploiting, if you will, those psychological variables in the biopsychosocial model. Now, biopsychosocial, of course, includes social, and social factors that are related to drug use involve things like peer groups. So you likely use drugs or alcohol in ways that are similar to those members of your peer group. If you're among friends who just typically don't drink or don't smoke cigarettes, you're unlikely to drink or you're unlikely to smoke cigarettes. If you're among friends who drink or smoke or do drugs, you're likely to do that too. We all tend to imitate or conform to the groups that we're a part of, and often that's just fine or even good or healthy. But if you have friends who have drug or alcohol problems and you yourself are trying to not have drug or alcohol problems, well, that's a problem, or that can be challenging. And so part of the biopsychosocial model, or part of thinking about treatment in a biopsychosocial way, involves recognizing the role that social groups, peer groups, can play in drug use. Well, we've kind of already talked about this, but this is, I think, a lot of what community support groups do. Now, there are particular aspects of the 12-step system, and there are particular aspects of the SMART or rational recovery systems that may be important. But I think a lot of what these groups do is they just provide you with a new group of friends to hang out with, people who are all unified by their desire to reduce or eliminate their drug use. And if you're someone who only hangs out with people who do drugs, it can be hard to stop using drugs, because if you stop hanging out with your friends, it can feel lonely, and loneliness is not pleasant, and it can make you feel unhappy and can even encourage you to go back to using drugs. Wouldn't it be nice if you could hang out with a new group of friends who you can bond with over the fact that you're all trying to not use drugs? Again, there may be more to community support groups, but the big part is providing support, providing other people, other local norms, if you will, that discourage drug use. And that's probably a lot of why those programs tend to be helpful, is they act upon this social element or social factor or variable in the biopsychosocial model of treatment. So the important point here is that different factors or variables contribute to drug use. There are biological factors, psychological factors, and social factors. Now, ideally, we could try and intervene on each of these levels. That's not always possible, but it would be ideal, because if we could, then hopefully we could change, or we'd have the best chance of changing any one drug user's behavior. In the area of mental health care, especially in the area of drug and alcohol use disorder treatment, we sometimes call this integrated treatment, suggesting that we're trying to integrate elements of medication support to address biological factors, psychotherapy to address psychological factors, community support to address social factors. This is probably the best approach if it's possible. Now, there may be times and situations in which you can't hit all these different areas of the biopsychosocial model, but it serves as at least a reminder and hopefully an ideal to strive towards. If you were someone who's seeking treatment for drug or alcohol problems, you might ask your healthcare provider, are there medications that I can use that will help decrease my craving or decrease my chances of relapse? Are there therapies that I can attend? Are there any community support groups? If you can address as many, or if you can hit as many of these targets or variables, then hopefully you're increasing the chances that you personally can reduce or even stop your drug use. Okay, with biopsychosocial model as kind of a preface or a preamble, let's start talking about specific forms of treatment in the area of kind of formal treatments for drug and alcohol problems. One type of treatment that you've probably heard of or seen in movies or TV shows is detoxification, or just detox. As you'll see in the coming slides, it's not by itself a complete form of treatment for drug and alcohol problems. It doesn't cure the disease, so to speak, but it can play a role in helping people reduce or stop their drug or alcohol use, at least in some cases. Detoxification is just simply controlled drug withdrawal. When people stop using drugs or cut down their use of drugs, they typically experience a withdrawal syndrome, a syndrome being just a collection of symptoms and signs that are associated with not using drugs, and often are kind of the mirror image of the drug effects itself. So for instance, if you take opiates, the effects you have from those drugs may be decreased pain, decreased anxiety, feeling calm and safe and happy. When you're withdrawing from those drugs, you have increased sensitivity to pain, increased anxiety, feelings of being on edge or uncomfortable or even physically sick. That's unpleasant stuff. Those are the withdrawal symptoms. Those are part of the syndrome of withdrawal for that drug. And detoxification is a way to help you get through that, hopefully in a way that's safe and comfortable for you. So withdrawing from some drugs, to be clear, is just frankly dangerous. And the best example here is severe alcohol use. If you are a heavy alcohol user for a long period of time and you try to stop using alcohol suddenly, you can experience seizures or a condition called delirium tremens, or the DTs. You can experience severe dehydration, changes in heart rate. You can even literally die from it if you're a heavy drinker who tries to stop very suddenly. And so part of detox for people who are heavy alcohol users is providing them with various medications and health support so that they are less likely to become severely ill or even die as a result of their withdrawal. Some withdrawal is just unpleasant. you've seen in movies or TV shows probably images or depictions of people withdrawing from opiates, like withdrawing from heroin. That's actually not really dangerous to your body. It just feels really bad. So when you're withdrawing from heroin, you feel achy and sick, and you maybe have diarrhea, and you feel weak and anxious and irritable. None of that is going to literally kill you. I mean, you could get really, really dehydrated from the diarrhea, I suppose, but it's not particularly dangerous to your body. It just feels really unpleasant. The problem there is that that unpleasantness can be cured by going back to drug use. And if you have any experience with drugs, you know that, and it's powerfully tempting to get back onto using drugs to avoid feeling sick from withdrawal. This is, of course, negative reinforcement for use, for relapsing. We sometimes call this physical dependence because the symptoms of withdrawal for some drugs, like opiates, are kind of physical in nature, but they don't have to be literally physical. There could be other things like feeling anxious, feeling edgy, or kind of feeling angry or irritable. Those things are unpleasant for most people, and if using drugs makes that unpleasantness go away, it's very easy for people to relapse, and for that use, that relapsing use, to be reinforced via negative reinforcement. So whether relapse is frankly dangerous to you or merely just very, very unpleasant to you, it may make sense to do it in a safe and controlled environment. And if you do, that's detoxing. That's going through a formal detoxification process. You could do this on your own, but it might not be safe, it might not be very pleasant, or you could do this in a hospital or clinic where you can be provided with medications if necessary, nutritional support, nursing, etc. People who can help take care of you as you get through those difficult days and weeks of detoxing. You can ask, does this detoxification work? Well, it can help clients withdraw from alcohol or from some drugs safely. So if you're trying to withdraw from alcohol use after a long period of heavy alcohol use, you can do so much more safely, less likely to become injured or dead as a result if you do it in a formal setting. It can help clients manage their withdrawal symptoms. So you can give people medications to ease their pain, you can give them sort of sedatives to make them feel more relaxed so that they're not quite so edgy and irritable during their withdrawal from opiates, and that can decrease their likelihood of immediately relapsing into drug use. But to be clear, just getting off of drugs, just detoxing, doesn't ensure your long-term treatment. And this is something that I worry about a little bit when I watch TV shows or movies that depict people going through detox, and then it's like they're cured. Like, oh, I'm cured of that heroin habit, or I no longer drink alcohol because I've been through detox. That's not very accurate. The best we can usually say about people who go through detox is at the end of that program, unless they've been cheating or unless the program is poorly run and it's people are sneaking drugs in or whatever, at the end of the treatment, the detox treatment, the person's no longer using. That's good, but what will happen the next day or the next week or the next month? Hopefully there's some sort of other treatment lined up that can help them maintain their sobriety or maintain their controlled drug use. The important point here, I guess I'm being a little bit repetitious, is that detox can be helpful for some drugs or really necessary for others. The drugs, especially like alcohol, which if you use it heavily enough for long enough, you really need medical support when you withdraw. But it doesn't permanently treat dependence. More treatment is almost always needed. And in the remainder of this lecture and in the future lectures, I'm going to talk a little bit about what these other options are. So one of the other options, at least for some drugs, is using medications to help people overcome their addiction to drugs or alcohol. Now, this isn't the case for all drugs. It's not the case that all drugs can be treated with medications, but it is the case for some, particularly for the opiates, which I know I've talked about before. I've mentioned naloxone. Naloxone is a drug that binds to opioid receptors and blocks the effects of those drugs. As I mentioned earlier, it can counteract an overdose. So if you are overdosed on fentanyl, if you're overdosed on heroin and you're dying, you're starting to go into coma, your heart's slowing down, your breathing is becoming erratic, hopefully the police or paramedics who are attending to you will give you an injection of naloxone. It will block the opiate receptors that are being overactivated by the drug, and it will save your life. As I mentioned earlier, you can be given naloxone on an ongoing basis, and if you do, it won't really harm you at all, but it will curb the effect that you get from any use of opiates. It'll make the drugs less pleasant to use, less reinforcing to use, and you'll hopefully feel less craving to use drugs as a result. One thing we can do is give people drugs to lessen their craving, especially in the case of the opiates. Another thing we can do for some drugs is just maintain them on a safer alternative. This is called maintenance treatment. And again, it works particularly for opiate drugs. So I've mentioned in previous classes methadone. Methadone is a synthetic opiate. It can be given by a trained nurse or physician at a methadone clinic. And what it will do is provide a level of relief from withdrawal symptoms. So if you're addicted to heroin, or if you're addicted to fentanyl or OxyContin or whatever, part of the reason you may be unable to quit using is because when you do, you go into withdrawal. If you try to quit and then take methadone on a daily basis, showing up at the clinic every day for your methadone, the methadone will prevent you from going into withdrawal, but it's not a drug which is potent enough to give you a very strong high. So the nice thing about methadone, at least from a treatment perspective, is it's relatively long lasting, so it keeps you out of withdrawal for a fairly long period of time, but it doesn't really make you feel particularly high. So it's not like you take methadone and you collapse in the corner for 4 hours. You can go to your job, you can take care of your kids, and do other things like that. Methadone can be very helpful for some people, but it has some downsides. I mean, it is essentially treating one drug addiction with another, which I think some people object to, although I guess it's a matter of preference. Methadone's safe when used properly, but it has to be dispensed at a clinic because it's something that you could overdose yourself on if you gave yourself too much of it. It has to be given by a trained professional. As I mentioned in previous classes, and I'll quickly return to right now, there are newer drugs like buprenorphine and Suboxone. These are drugs which work like methadone, but are engineered in such a way that they can be prescribed in pill form and you could take them at home. So if you lived in a community where there wasn't a methadone clinic, or if you lived in a community where there was a methadone clinic but you didn't want to go there because you fear the stigma associated with being an opiate user, you don't want people to see you, or understandably you're kind of scared of the whole situation, you would be able to take buprenorphine at home, and you can't really overdose yourself on it. It's safer in that respect. Suboxone is just a drug which, as you can see, is a combination of buprenorphine and naloxone, and it's designed to kind of hit two of these biological factors. It kind of blunts your craving, that's the naloxone. It also manages your withdrawal symptoms, that's the buprenorphine. So the important point here is that medications can be helpful, especially for some drugs like opiates, and to some extent for alcohol. There are some other medications which can be useful for alcohol, but they often need to be combined with other forms of treatment. In the future classes, I'll give some examples of combined forms of therapy for opiates, for alcohol, and so on. But the basic idea is that using our biopsychosocial model for thinking, we ought not to expect that just giving people medication is going to be helpful. In some cases it might, but in other cases we're going to want to look to add in psychotherapy of some sort, and also some kind of community or social support as well. With that in mind, let's take a look at the preview. Next time around, I'll just be talking more about treatment, focusing then a little bit more on psychotherapy and on some examples of different forms of integrated treatment for different kinds of drug or alcohol problems. So as I always say, thanks for your attention. I appreciate it, and I'll be back in the future with some more stuff for you to look at and listen to. I hope this was cool. I enjoyed talking about it, and I'll be back soon. Bye-bye.